and came across this meme, and I was like, oh my God, that's the funniest thing. Because for women that have had OBGYN exams, female exams, it's always what it is. Okay, move down a little more, a little bit more, a little bit more, a little bit more. Okay, just a little bit more, a little bit more. Like, oh my God, I'm gonna fall off. You're not gonna fall off. I'm not gonna let you fall off. Just keep coming, keep coming, keep coming. And that's every single time. And so, what I started doing after reading this, I would put my hand there, okay, come all the way down until you can feel my hand. And then I'll have you stop. And that way they're not like, okay, a little bit, a little bit, a little bit. Because every time they come, it's like when half of the sending. Because they're so afraid they're gonna fall off the other way. No, you're not gonna. So that made me that. All right, we're gonna talk about complication of pregnancy. We talked about already normal pregnancy, we talked about maternal physiology. Now we're going to talk about some complications that we can see both in first and second trimester pregnancies. This is part 1 of 2. And then we'll end up with our last 2 lectures, which are labor and delivery complications. All right, let's do a quick review. The 21-year-old comes in G2, P1, 7 weeks. First trimester nausea that has been persistent. Despite eating small meals, she's not eating her prepared foods. What is the next most appropriate intervention for her? B6, pyridoxine. So we really want to avoid antiemetics if we can. Okay, they're not without a lot of side effects. So even ondansetron has side effects, and depending on what literature you read, although we know for pharmacy nowadays they don't do pregnancy categories, but this used to be, we call them pregnancy category C, which means the benefit outweighs the risk. And definitely with metoclopramide, and then with Phenergan as well, those have a lot of side effects. You want to be careful if you're not prescribing. So pyridoxine with Unisom, that would be a good initial choice after doing some diet modifications. When would that person need to be hospitalized? Yeah, they're completely PO intolerant, or they have electrolyte derangements, they're spilling a bunch of ketones in their urine, then they might need to be hospitalized with IV hydration. But most of the time, that's not the case. And if that happens, it's about hyperemesis gravidarum, and it is a thing. They're not gaining weight in pregnancy, that would be concerning, and they'll hospitalize them, and then they'll give them fluids in the hospital. Or you've got a 32-year-old that comes in at 19 weeks, having low back pain, been worsening during the second trimester. It does appear to be musculoskeletal in nature, not to be contractions. What do we think the treatment for this might be, the initial treatment? I'm going to go with alpha, acetaminophen. I need to go with echo, bed rest. No, I don't want a bed rest. Get up, 2 things, right? Because these patients are already in a hypercoagulated state just by being pregnant, and the more they lay around, the more an increased risk of DVTs and PEDs. So we can give them acetaminophen that is safe in pregnancy. What we don't want to give is anti-inflammatories like ibuprofen and oxysodium. Remember, your patients often use over-the-counter medications, so they're going to come and say, I'm going to take a leave. Okay, well, what is a leave? What's the other name for a leave? Naproxen. Okay, but they don't know that. Well, I've been taking ibuprofen and Motrin. Well, it's the same thing, but your patients don't know that, so you've got to educate your patients. In general, we don't want those just acetaminophen, and definitely not hydrocodone. All right, let's talk about first trimester bleeding. First trimester, remember we break up our trimesters into 14 weeks apiece. We're going to talk about less than 14 weeks in general. Okay? So some of these go on into our early second trimester as well. First trimester vaginal bleeding, very common. 1/4 of all pregnancies will have some sort of bleeding in their first trimester. And there's a lot of different causes, from subchorionic hemorrhage, get an ectopic pregnancy, certainly they get a miscarriage, also known as a spontaneous abortion. We'll talk about implantation bleeding, which is pretty common. And then things like uterine fibroids. People can get pregnant even though they have uterine fibroids, and those uterine fibroids can still cause amputation. Okay? They can have cervical polyps, they can have warts and infections that all can cause vaginal bleeding. So we'll talk about each one of those. When they come in with this vaginal bleeding, the biggest thing is we got to get that good history. okay, and not just their history surrounding their vaginal bleeding, but we're gonna get their reproductive history as well, okay? How many previous pregnancies have they had? Were there any complications in those pregnancies? How did the deliveries end, and how were the deliveries, vaginal or C-section? What about any STI history? When was the most recent one, and what was it treated with? We want to make sure it was appropriately treated. Do they have any significant past medical history, especially hypertension, diabetes, because that often tends into pregnancy as well and continues on. And what about any known uterine anomalies? Again, do they have something like uterine fibroids? Do they have endometriosis? Do they have adenomyosis? All of those things outside of pregnancy can cause abdominal bleeding, and you can have abdominal bleeding in pregnancy as well. We want to identify what is this bleeding like. Are they just spotting a little bit? Are they passing clots or soaking through their sanitary products? If so, how often are they changing their sanitary products? Is it in constant for the time period from the beginning until you're seeing the patient? Or does it seem to come and go? No, I only have it after I have intercourse. Well, then maybe that might be a cervical polyp. That may be causing it only during after intercourse. Okay? Is painful or painless? That's really important to identify as well. And then do they have any systemic signs and symptoms that may make you think that either they might be underrepresenting the amount of bleeding that they're having? Every time I go to stand up, I feel like I'm going to pass out. Well, that would be concerning, right? Or I did pass out when I stood up. So lightheadedness, dizziness, pre-symptoms, you want to identify that. For a physical exam, it's going to include abdominal exam, which include the pelvic exam in there as well. We're going to try to identify if they have any abdominal tenderness. And then on pelvic exam, we talk about speculum exam. We're looking for externally, you're looking for blood, and then in the vaginal vault, we're looking for pooling of blood. We're looking for blood clots as well. You're going to look at the cervical os. Is there any sort of clots or tissue that's coming out of the cervical os? Is the cervical os open or closed? So it depends on where you go for your phase 2, depending on how many OB exams that you do. But for them to identify the cervical os and the dilation of the cervical os, they just use their fingers, okay? And so if you can just put the very tip of your finger in there, it's usually a closed cervical os. And then 1 centimeter, you can kind of put the very end of your finger in there, and then it goes on from there. And the providers know by the size of their finger what the centimeter is. So we're looking to see if this is maybe open or closed. And again, any sort of tissue that's in there. If you do see any tissue, it's really important to try to get that tissue out of the cervical os, because if it stays in there, that's a pathway for that bleeding to continue. So you just take a pair of ring forceps and you pull that tissue out and you put it in a formula cup, and then you just send that off the lab. Maybe there's some other reason why they're bleeding. Look along the vaginal walls. Make sure there's no lacerations. And make sure you don't have any lesions there. And externally as well, no lacerations or lesions. I do recommend doing a bimanual exam on these patients and evaluate the uterine size as this patient comes in. They say, I should be about 6 weeks by last menstrual period, but you're feeling the uterus size all the way up by the pubic symphysis. That would be abnormal. Or I'm supposed to be 6 weeks, or I'm supposed to be 12 weeks, and you don't feel anything at the pubic symphysis. The other thing you want to do on that bimanual exam is feel the adnexa. Because we know that normally we won't feel anything in the adnexa, but if you feel some sort of unilateral mass, that may be from something like an ectopic pregnancy, and that may be a cause for the vaginal bleeding. For labs, CBC is going to be one of the most important labs, along with an HCG. Remember, we never believe our patient's pregnant until they have a positive HCG. And usually we're going to do an HCG quant, especially if they have bleeding, because we are trying to identify is this a viable pregnancy or not? Meaning, is this pregnancy good or it's not good? And HCG today is going to help us in a couple of days from now. We tend to see increasing HCG numbers. If we don't, and it's decreasing, then that leads us to believe that this might not be a viable pregnancy. For CBC on that, we're going to look at H&H. And oftentimes, it's not just one H&H. Depending on how much this patient is bleeding, it might be in a couple hours from now, and repeating this H&H, especially if the plan is to send this patient home. You want to make sure that their hemoglobin hematocrit are stable, and not downtrending that indicates ongoing blood loss. Okay? Rh type is ABO Rh. We want to know what is their, are they Rh positive or Rh negative? Okay? And what is their blood type? A positive, O negative. That way, if this person ultimately needs blood products, then we have them type and cross for that, or type and screen. If they are bleeding significantly, evidence of hemodynamic compromise, then you might want to type and cross them. Remember, when you type and cross, you're holding blood for that patient with the expectation that you're going to give the blood to that patient. All right, so let's go into these different causes of first and maybe early second trimester vaginal bleeding. So chorionic hemorrhage, probably one of the most common causes of vaginal bleeding we're going to see usually for women on 10 to 20 weeks. And these patients will come in with painless, bright red vaginal bleeding. So painless, bright red vaginal bleeding. Occasionally they'll have some very mild abdominal cramping, but most times it's really painless. We just had this kind of sudden gush of bright red vaginal bleeding that came out, and that's what prompted me to come in to see you. And so when we think about the subchorionic area, okay, so this is our amniotic sac, and the chorion is kind of just surrounding the amniotic sac and around the placenta. So we call it kind of the fetal portion of the placenta, if you will. And there's bleeding that occurs between those two sacs, between the chorion and the amnion and the baby. If that subchorionic hemorrhage is greater than 25% the size of the gestational sac, then it increases the chance that this is ultimately going to end in a miscarriage or spontaneous abortion. And how do we get that number? We get that number because of an ultrasound that we do. Anybody that comes in with vaginal bleeding and pregnancy, you're going to want to get an ultrasound. The radiologist is going to report to us what that number, what percent that is, that subchorionic hemorrhage is. Once this is identified, unfortunately, there's no specific treatment for it. The majority of times, this is going to go away, get better as the pregnancy goes on. If it is larger in size, or if radiology recommends it, they may say OB consultation is advised, or repeat ultrasound in 1 to 2 weeks for further evaluation. And like I said, radiologists will give us that information. For these patients, if it's later on, more that towards that 20 weeks, they can have an increased chance of placental eruption if this isn't diagnosed until a little bit later on, or can increase the risk of premature rupture of membranes as well. So those are some complications that we'll see in that using that third trimester. And spontaneous abortion. Another cause of first trimester vaginal bleeding. And remember, we think about spontaneous abortion as a pregnancy loss before 20 weeks of gestation. Another name that we commonly use for spontaneous abortion is miscarriage. Okay? About 20% of all pregnancies will end in will have a miscarriage, and about 80% of those are going to occur in that first 12 weeks. So 20% is a lot. That's a lot of pregnancies that end in spontaneous abortion. Now, when we think about spontaneous abortion, this is occurring just out of the blue. Okay? Usually there's no specific rhyme or reason why this is occurring. And that is different than when we think about induced abortion. So induced abortion is the intentional termination of the pregnancy. And we separate them into therapeutic, meaning there's a medical reason, usually mom has a reason why we're inducing the abortion, versus elective abortion, the patient is choosing to have the abortion, unrelated to mother's health. It may be related to baby's health, okay, but it's unrelated to mother's health. So therapeutic, something's wrong with mom, and medically she can't carry the baby, and then elective is the mom decides to terminate the baby. Okay, now we make sure you understand the difference between those two. Okay, and then other definitions associated with spontaneous abortion or miscarriage. So threatened abortion, vaginal bleeding, okay, less than 20 weeks. There is fetal cardiac activity on ultrasound. The os is closed, okay, meaning that this is there's a potential this will end in a miscarriage. Okay, up to 50% of these will end in miscarriage. That means 50% will not. Okay, as long as that os is closed, there's a 50% chance mom will continue to carry this baby without any complications throughout the entire pregnancy. Okay, inevitable abortion, vaginal bleeding. Here the os is open. Inevitable means what? It's going to happen. Os is open. Think about the os as a door. If the os is closed, we're keeping the baby in. Once that os is open, there's nothing we can do. This will ultimately end in fetal demise. Now, you may have fetal party activity on the ultrasound right now. If that os is open, it's a non-viable pregnancy. It will end in fetal demise. Okay? Inevitable can come in incomplete, meaning there is still that dilated os and there is passage of some of the products of conception, which is POC. So in other words, the embryo, some of that is remaining in the uterus. Okay? And usually they require some sort of surgical intervention to get that out. Okay? And then you can have a complete. A complete means the cervical os is dilated and mom has passed all of the products of conception. And once that happens, then the os is going to close again, and they're doing an ultrasound to make sure that we don't have any retaining products of conception. And we can have a missed miscarriage or missed spontaneous abortion. Here on ultrasound, we see an embryo in the uterus. We do not have any fetal cardiac activity. Os is closed. Okay? So the fetal demise in the uterus, os is closed, means that at some point, we're not really sure when, but the embryo was no longer viable. Okay? Again, for these patients, oftentimes we'll have to do a DNC, we'll have to do something to dilate the cervical os to allow them to expel the products of conception. Okay, if they have three or more successive abortions or 3 or more spontaneous abortions, that is considered reoccurrent. Okay? And if for patients that come in with reoccurrent miscarriage or reoccurrent spontaneous abortions, we want to think about reasons why. Is it some sort of genetic testing that needs to be done on these patients? Does the mom have some sort of infection that has been undiagnosed and untreated? Maybe mom smokes and drinks. And we're going to talk to our mothers about that as well. If they have any chronic medical conditions that are not optimized, like diabetes, hypertension, or things like lupus, that increases their risk of recurrent miscarriage as well. Okay. We talked about cervical incompetence before, and for those patients that have recurrent cervical cervix surgeries, increased risk of cervical incompetence. Bottom line is, having these recurrent miscarriages, you may be the first one to identify that. When you're looking at their GPTAL history, like, how have you had 6 pregnancies but 0 live births? What's going on here? Let's figure out what's going on, because that would be a little unusual. Okay. Another thing that can cause recurrent miscarriages is, stress. Stress that mom is incurring. We're going to talk to them about that. So this is a kind of graphic representation of those different types of miscarriage or threatened. The thing about threatened, the os is closed. We have that vaginal bleeding. Okay, inevitable, os is open. We can see here. Os is open. We have some retained products of conception. Incomplete. Okay, here we have os is open. Okay, and some fetal tissue is out and some stays in there. And then missed, we have os is closed, and then a non-viable pregnancy in the uterus. Okay. Again, when you're studying, you really need to make sure that you understand the difference between all of these. Threatened is the only one. Here you have the os is closed besides missed. Okay, missed, fetal demise, and evidence so. So you see the difference between threatened, you have cardiac activity, missed, fetal demise, no cardiac activity. Both of them, the os is closed, both of them have an embryo in there. But the difference is one does not have any fetal cardiac activity. Okay, so most commonly we have a first trimester miscarriage, a first trimester spontaneous abortion, It's usually due to some sort of chromosomal abnormality. Something prevented proper implantation. And oftentimes, about 50% of the time, it's going to be for some sort of trisomy, since that's the most common aneuploidy that we see. If it's in the second trimester, now we do think more about, maybe mom has a factor in this in that second trimester. So maternal systemic diseases, alcohol use, smoking, all of those increased risk of miscarriage in that second trimester. Again, maybe the placenta itself didn't form correctly. And if they have a history of that spontaneous abortion, you want to think about the smoking. Maybe they have an IUD in place. Remember, it's not likely to get pregnant with an IUD in place, but if they do, then it can either be ectopic or it can result in a miscarriage. Okay? If they have uncontrolled hypertension and more commonly uncontrolled diabetes in pregnancy, it increases the risk of second trimester pregnancy loss. Things that are not related specifically to pregnancy loss. Moderate caffeine. Remember, moderate caffeine, that's a cup or two a day or less than 300 milligrams a day of caffeine. Intercourse. Unless someone has a complication with their placenta, intercourse tends to be okay throughout the pregnancy. And then exercise. There are a lot of women that are exercising up until the day or two before they have the baby. That's not a cause of miscarriage. Remember that you always want to have your differentials. Your differential for someone coming in for vaginal bleeding, abdominal discomfort. This could still be a viable pregnancy. It could still be a viable pregnancy, even if they have vaginal bleeding. So we don't want to talk to our patients about this is definitely going to end poorly. We want to talk to our patients about there's a possibility, because vaginal bleeding in first trimester is very common. It's a good possibility you can carry this pregnancy to term. It's just too early to determine. It's too early for us to determine. And then another differential we want to think about is that topic that's associated with this. Complications of miscarriage, hemorrhage. These patients can hemorrhage in two ways. It can be very obvious where as they're wheeling them back to see you, they bled over the entire floor. Or it could be this slow oozing. We almost lost a patient a few weeks ago at BMC. The nurse kept telling the doc that was on, like, hey, this lady is bleeding. He's like, oh, it's gonna be fine. She goes back an hour later. But she is bleeding. She's not pouring out, but she's just going through chuck after chuck after chuck after chuck. We're waiting for OB to come down, So 6 hours later, this lady is sick. Her H&H is like, 9 and 4. She's a black lady, completely pale, lips are white, like now we're 6 hours into this, right? And that's because she wasn't obviously pouring out blood. So don't be mistaken by that. Oozing can cause just as much thing. It's just going to take a lot longer for that to happen. Right? If they have retained products of conception, they'll have significant heavy bleeding. And so we want to make sure we identify that retained products of conception by doing an ultrasound. People that have had even a D&C before, if they have a miscarriage, they may come back a few days later and say, I was under the impression that my bleeding would stop within a couple of days, but now I'm 5 or 6 days later and I'm still having this bleeding. They warrant an ultrasound to make sure they don't have retained products of conception. Because if they do, they're going to continue to bleed. They can certainly get infections like endometritis. Okay? And that's because we know that endometrium and that endometrial lining gets infected, and then sepsis can occur as well, depending on how the spontaneous abortion occurred and where it occurred. Okay? We know that there are a lot of state laws nowadays that patients can't have abortions, and so they'll go to many lengths to have these abortions done, and sometimes they'll come in and be very sick from it. All right, so the problem again is that abnormal bleeding in that first trimester is super common. It's super scary for the patients, so we want to empathize with our patients and let them know that I understand this is a really scary time for you, but this is a very common occurrence in the first part of pregnancy. There's a lot of people that have vaginal bleeding, they go on to deliver full-term, completely healthy babies. We want to tell our patients that, right? So For women that are, probably 11 years old, all the way up to around 55, we want to make sure when they come in with vaginal bleeding that we get an HCG on that. And we talked about HCG levels previously, where when we look at these HCG levels in that first trimester of pregnancy, we expect our HCG levels to rise pretty quickly. Doubles about 2.2, doubles about every 2.2 days. So we say about every 2 days we should see a doubling in our HCG levels. And so that's why it's important to get that quantitative HCG. We need a number. So when these patients come back 3 or 4 days later, and they say, no, I'm still having this bleeding, it seems to be getting worse, we're going to repeat that HCG level and probably repeat the ultrasound. If our HCG levels are decreasing, okay, that is a concern that the patient is undergoing some sort of spontaneous miscarriage or spontaneous abortion. If our serum levels are increasing, okay, that's good. We like to see that, but we like to see that doubling. And so if it's increasing just by 1 time, so they come in, they're 750 and now they're, about 900, it might be an early indication that this patient's having an ectopic. So a lot of times with ectopic, you won't see that full doubling. You'll see about 1 to 1.5 times increase of that HCG level. So it's really important to get that quant, so we can help that quant helps us follow these patients to either a successful pregnancy or fetal demise. So indications on ultrasound. We're going to use ultrasound along with that HCG to evaluate these patients. Indication that this is a viable pregnancy. If you have a gestational sac, we should see it around 4.5 to 5 weeks. And do not memorize these HCG numbers. I'll tell you which ones to memorize, but these ones, because HCG numbers vary from person to person. Some person might be 1,500, some might be 3,000, one might be 750. But we think in a normal scenario, we have gestational sac on 4.5 to 5 weeks, HCG levels around 1,500. And we should see a yolk sac around 5 to 6 weeks, coming from the last menstrual period. A fetal pole about 5.5 to 6 weeks. The HCG at that point, once we see the fetal pole, is upwards about 5,000. And then we should be able to see some sort of cardiac movement, some sort of fetal heart tone around 5 to 7 weeks, and HCG levels around 17,500. Indications of fetal demise. If we see a gestational sac without a yolk sac or fetal cardiac motion or movement, that is concerning that this is a non-viable pregnancy. Okay? Crown to rump length. Remember, we use that crown to rump length to help us identify how far this pregnancy is in addition to our last menstrual period. If it's greater than 7 millimeters, but we do not see any fetal cardiac activity on ultrasound, that is concerning that this is a non-viable pregnancy. This is going to be fetal demise. Mom may not have miscarried yet, but ultimately the body will recognize that this baby is non-viable, and we'll try to push that out in the form of a miscarriage. So again, I would definitely that crown to rump length, I would remember that. So this is a couple pictures. That first one is a gestational sac, but we don't see anything inside that gestational sac. Okay, so this is what we call an embryonic gestation. Either mom lost this baby very, very early on within the first couple of weeks, or the baby never really even formed well at all. Okay, so embryonic. And this is what we normally see for a normal pregnancy. We have our gestational sac, a really large sac. We have our yolk sac, and then we have our fetal pole. So by looking at these images, you can come back to here and say, okay, I see, I should have a yolk sac, I should have a fetal pole. If I have a gestational sac and I don't have those things, then that would be concerning for a non-viable pregnancy. And remember, this is a really difficult time. Even though we try to convince our patients that first trimester bleeding is not unusual, we spend a lot of time reassuring the parents, reassuring that a lot of times they think it's something that they did. Especially mom thinks it's something. I knew I shouldn't have went for that run. I knew I shouldn't have ate those tacos. I knew I shouldn't have done this or that or the other thing, right? But really, we gotta spend a lot of time reassuring these patients and letting them know that first trimester pregnancies really have nothing to do with what they've done or have not done. Okay? If they feel guilty, we wanna try to alleviate those guilty feelings by just letting them know that it's not their fault. Otherwise, we do expectant management the majority of the time, which would really just watch the wedding, allow the natural process to take hold and allow the body to expel the embryo in a natural form. If the patient is unstable, and now we talk about 2 large bore IVs, maybe giving them fluids, maybe giving them blood, we got to identify that hemorrhage kind of early on. And if you find that you're getting ready to discharge these patients home and you're monitoring these patients, they have this constant bleeding, then we want to repeat that H&H to identify their initial H&H and before they go home, what is their repeat H&H. If they don't want to expectant management, you can offer them medical management. Medical management has changed a little bit just in the last couple of years. We used to only use misoprostol. But now we use mifepristone as well. So mifepristone can be used, and it's usually, the recommendation nowadays is use them together. So you're going to do both mifepristone and misoprostol. And then some of the times these patients need surgical management. Usually that's going to be in the form of DNC. So dilatation and curettage, what they're going to do is dilate the cervix, and they're going to take a suction, and they go in and suck the inside lining of the uterus and suck the non-viable pregnancy out. There's a lot of literature, really just in the last 6 months, that talks about the DNC should be able to be done in the emergency departments now. Okay? So by the emergency department providers, by the PAs and the NPs and the docs, not OBGYN. We think that this can be managed in the ER. We are not doing that in our ER yet, but it's hard to say. It's something that you guys may see when you go to phase 2, if that's something to manage. Okay. In general, these patients are Rh negative. We want to think about RhoGAM, especially if they're greater than 12 weeks. Less than 12 weeks, nowadays they say RhoGAM is probably not necessary. Greater than 12 weeks, counseling should be provided for all these patients. You should get a referral in for counseling. And then if it's reoccurrent, then we want to think about the reasons. Go through different reasons for them to be reoccurrent infections. And if you can't figure it out, then there's nothing wrong with putting a referral for these patients to OBGYN. They can expand the differential cause for reoccurrent miscarriage. Okay. Ectopic pregnancy. Ectopic pregnancy affects about 2% of first trimester pregnancies. When we say about 3% of pregnancy-related death, it's probably even higher than that. Some literature will say up to 10% of pregnancy-related death are specifically related to ectopic and ruptured ectopic pregnancies. So ectopic pregnancy occurs when that developing blastocyst becomes implanted at a site other than the endometrium or the lining of the uterine cavity. It can occur anywhere else. It's most common to occur in the ampulla. So it's most common to be a tubal ectopic pregnancy, and then the ampulla is where it's going to go. There's a lot of risk factors that can increase someone's chance of having an ectopic pregnancy. Anything that changes the structure of the fallopian tube and the fallopian tube anatomy, especially if they had some sort of prior surgery or prior infection that can cause that. Okay? If they've had a prior ectopic pregnancy, they're about 5 times more likely to have another ectopic pregnancy. And again, prior STD or we call it tubal infections, so things like salpingitis, PID. That can cause scarring of the fallopian tubes, and that increases chance of tubal pregnancy as well. If they have appendicitis, not necessarily the appendicitis actively, but the appendicitis, if the appendix gets really inflamed, the fallopian tubes are not that far away from the appendix. Okay, so ultimately they can get scarring from that previous appendicitis that affects the fallopian tube. Increased risk for people with assisted reproductive technology increased risk of ectopic people that smoke. So we're going to talk to our patients about smoking. And then again, IUD. If they have an IUD in place and they get pregnant, which is unlikely, but if they do, it's more likely to be an ectopic pregnancy. So classically, these guys will present with amenorrhea because they're pregnant, okay? They have abdominal discomfort, and then they'll come in and say, I was doing okay. I didn't have, my last menstrual period was 16 weeks ago, and then I started having some spotting in abdominal pain. So anytime anybody pregnant, especially early on, they come in with abdominal pain, ectopic needs to be the number one diagnosis. If they have a rupture, an ectopic rupture, now they're going to come in very symptomatic, severe abdominal pain, just like we talked about with ovarian cyst rupture. A severe abdominal pain, severe pelvic pain, oftentimes hypotense, tachycardic. But the other problem is they can come in with just general pregnancy symptoms. Okay? So they can come in and say, yeah, I feel a little queasy, have a little bit of abdominal discomfort, a little bit of cramping, a little bit of bleeding, I feel a little bloated. So sometimes there can be really nondescript signs and symptoms. So you've got to have a high index of suspicion for any pregnant patient that comes in with vaginal bleeding that ectopic might be the cause. On physical exam, we like to see abdominal tenderness. We won't see, you may not always see that. A bimanual exam, oftentimes they're very tender on bimanual exam on one side, the side of the ectopic. Okay, you may see behind the cervix in that posterior fornix area, you may see a bulge. Okay, and that's usually more indicative of a ectopic rupture associated with bleeding, or like a pouch of dilatation. The uterus itself might be a little bit larger from inflammation. And then again, if they've had some sort of rupture, we're talking about hypotense, hypovolemia, they may, so if someone comes in childbearing age and they syncopate, what is your number one differential? This, ectopic, until you get a negative HCG. If you have a positive HCG, then now you're going down the rabbit. You're getting an ultrasound and you're getting a quant, and all that. Syncope in childbearing age is ectopic until proven otherwise. And then again, HCG levels. Look at that doubling every 2.2 days. Now, a lot of times it won't quite double. Maybe about 1 time, 1.5 times increase. And not always, but that's kind of what we look for. So these patients, again, we think about positive HCG in the setting of abdominal pain, usually about 6 to 8 weeks after the last menstrual period. We get a transvaginal or transabdominal ultrasound, usually because they're early on, it will usually be a transvaginal. Okay, and on that transvaginal, what we're looking for is an adnexal mass and no intrauterine pregnancy. Okay, we want a quantitative serum HCG. So we're doing our physical exam, we're doing our ultrasound, we're doing that HCG. And remember that most of the time, they're not going to do that ultrasound until the HCG level is back. Okay, now HCG levels. I know you guys probably don't do a tremendous amount of reading outside of trying to learn all this crap, but if you do, you may see some difference in the HCG levels. These HCG levels that we're talking about today have changed in the last 3 months. Okay? So less than 2,000 HCG, okay, doesn't mean it's not an ectopic, but we're not going to take any specific intervention. We want to repeat the HCG, repeat the ultrasound, and usually it's going to be about 5 to 7 days for that repeat. So that's more definitive. Greater than 4,000, if there's no IUP, that is concerning for an ectopic. Remember, ectopics don't always just occur in the fallopian tubes. They can go anywhere else. And so what they primarily look for is adnexal masses. If that's not there, but we have greater than 4,000 HCG, and there's no intrauterine pregnancy, there's an ectopic somewhere. Okay, you gotta get on the horn to OBGYN. The problem is this gray area, 2,000 to 4,000. 2,000 to 4,000, there's still a possibility, until it's greater than 4,000, that there's a viable pregnancy in there. Okay, so this is a phone call to OBGYN. What would you like me to do? What do we want to do? We're gonna have this patient come back in 2 days, repeat the HCG, repeat the ultrasound, and you guys are gonna follow them up in the clinic. But again, between 2,000 and 4,000, unless they have a definite adnexal mass on ultrasound, it's gonna be a gray area where they're not gonna take any specific measures until they can have more definitive answer on the ultrasound. Okay? So you need to be very familiar with these numbers, not only for the exam, but in real life, because you guys will be doing HCG levels on patients that come in. So you need to know when they come in with abdominal pain, what do you do with the HCG levels? Prior to this, our number was 2,000 and below. 2,000 and below, repeat. 2,000 above, it's ectopic, but that's not the case now. So we use 4,000 for that. Okay. So this is a fast exam. You guys know how to do fast exams, right? Something like that. And in this fast exam, this is what we talked about. So this is our kidney, this is our liver, and this is that Morrison's pouch. Okay. Is this abnormal? Yes. We shouldn't have black there. We should have this kidney that comes right up against there. But when you have this black there, that indicates fluid. And when you see that, especially in a person with a positive HCG, that is an ectopic pregnancy. And probably what? Ruptured ectopic pregnancy. Ruptured ectopic pregnancy. Because you shouldn't have free fluid, free blood in the abdomen unless there's a rupture. And that's how it's going to look. That's what will be how it presents on ultrasound. Okay. So unstable, and you're in a clinic somewhere, this is EMS transport to the emergency department. You got 2 large LVADs in these patients, you've got fluids running, and you got blood on standby. Because very quickly, these patients, very likely these patients could go down real fast. Okay. And the majority of times, we think about these patients coming in that 6 to 8 weeks, and we like to have abdominal pain, like to have vaginal bleeding, like to have all the things, an ultrasound that has an adnexal mass, but that may not be the case. Right? There's really no history or physical exam finding that you can say for certain this definitely is or this definitely is not an ectopic pregnancy. Okay, there are a lot of other things that present just like this: miscarriage, spontaneous abortion. Okay, they could have an ovarian cyst that ruptured, and that's what's causing their abdominal pain. They could have appendicitis. Because pregnant patients do get appendicitis. That's causing their abdominal pain. So make sure you keep your differential wide and start ruling in and ruling out those differentials based on your lab, based on your ultrasound, physical exam. Don't forget a urinalysis as well in these patients. And then sometimes it can be even more confusing. You can get something like a heterotopic pregnancy. So you do that ultrasound, you're like, yes, there's a baby in the uterus. Oh, wait, there's a baby outside the uterus too. Right? You get a heterotopic pregnancy. We do have a coexistence of an intrauterine pregnancy and an ectopic pregnancy somewhere else. Okay? This occurs more often with assisted reproductive technology, 1 in every 10,000. Otherwise, pretty rare, 1 in every 30,000. So pretty rare, probably not something you would see. Here's an ultrasound here, intrauterine pregnancy here. Look at that nice crown to rump length. But look at this one, also a nice crown to rump length. But this is an intracervical. Well, so between the internal os and the external os, this thing has planted itself and has grown. Now, that had to be uncomfortable. I mean, I would imagine that. Okay. So, what do we do for these patients? A couple of different options. We've got medical management, surgical management. So medical management, methotrexate has been around for a long time. You guys probably learned about that in derm. But it's also the treatment for ectopic pregnancies. Overall, does not decrease ovarian reserve. So that's nice because it preserves future fertility. It does work best if we have lower levels of HCG, small ectopic pregnancy without fetal cardiac activity. Does that mean that they won't give mom the option to take methotrexate if there is fetal cardiac activity? No, they will, but they also understand that it's probably not going to work as well, and these patients may be back for a failed medical management and then ultimately need surgical management. Okay, There are some disadvantages in general to methotrexate. So if you have a heterotopic pregnancy, this is a teratogenic. You cannot use this in a heterotopic pregnancy. If mom is breastfeeding, she cannot use this because it is excreted into the breast milk. Okay? Can affect bone marrow, GI mucosa. Is hepatotoxic, so if mom has a history of liver disease, also not a big candidate for methotrexate. So again, know the methotrexate is treatment, and then look at these disadvantages. Know that if mom is breastfeeding, we've got to go with some other option. We want to make sure that if mom does have an ectopic, another part of treatment is going to be Robiam if she is Rh negative. Surgical intervention is another option, especially if these patients are hemodynamically unstable, if they have a heterotopic pregnancy, if they have contraindication to methotrexate, if they failed methotrexate therapy, then those would all be reasons for them to do surgical intervention. And surgical intervention, they can do a salpingectomy where they open up the fallopian tube and take out the ectopic, or they can do a salpingostomy where they open it up, or a salpingectomy where they remove the tube itself. So ostomy, they're creating a hole, and ectomy, they are removing it completely. Another cause of first trimester vaginal bleeding is vanishing twin. Anybody heard about a vanishing twin? It's really just an early pregnancy loss as a multi-fetal gestation. So mom was pregnant with twins or triplets or whatnot, and one of those or two of those had fetal demise, early fetal demise. Again, more commonly associated with assisted reproductive technology. These patients come in, they can have vaginal bleeding, they could also pass a clot, and that clot was usually the baby, but otherwise they're stable. Vital signs are stable, they look pretty good, H&H is okay. We're still going to, of course, do that transvaginal ultrasound because we want to try to identify if there's a reason for them having to have this vaginal bleeding, and most importantly, want to make sure they don't have an ectopic pregnancy as a cause. Otherwise, no treatment necessary. And just because they lost one of the multi-fetal gestation, it does not seem to impact the other. As long as they, this vanishing twin, the early pregnancy loss, the other ones tend to be able to be carried to near full term. All right, let's take a break, and then we'll start up. See it? Anybody ever hear of it? Well, this is one of those really kind of cool pregnancy anomalies that I don't ever want, but to read about it and see, you're like, wow, that is really strange. And it's when you have this abnormal growth of the trophoblastic cells, the abnormal growth of the trophoblastic cells. Now, it could be complete, like you see in this first picture, where it's the whole uterus is filled with these trophoblastic cells, or it could be partial, where you have trophoblastic cells and an embryo. It can invade up into the uterus. It can also turn cancerous. So we're going to talk about those main things. So the complete, the incomplete, and then we'll talk about the cancerous one. That's how we're going to be able to focus. So again, we really just think about this as generalization is this abnormal proliferation or abnormal growth of those trophoblastic cells. And if you don't remember, the trophoblasts, okay, they are the cells that outline the embryo. So you got your embryo that's going to be up here, these are your trophoblasts, and the trophoblasts are what help the embryo kind of stick to the lining of the uterus, helps them implant to the lining of the uterus. And so they're really just this kind of one layer, two layer thick of cells, but for some reason in this disease, they grow out crazy. They take the space of this embryo and all inside here, they take all of that space as well, of the blastocyst. And again, we've got that complete, we've got that partial. More commonly, we see this in Asian women, Hispanics, American Indians as well. We also see it at the extremes of age, younger folks and older folks. For older folks greater than 40, 10 times higher risk of having gestational trophoblastic disease or a molar pregnancy is another name for this. Of course, if you've done it before, you can do it again and have probably increased risk of doing it again. 2 times prior complete moles, 20% chance that the next one is going to be a molar pregnancy as well. If you have one before, just a 0.9% chance. So women can still have completely normal pregnancies after a molar pregnancy or gestational trophoblastic disease pregnancy. So complete molar, these patients, their HCG levels are going to be through the roof. Remember we just talked about HCG levels doubling every couple of days. Right now, every couple of days, you're talking about 10 times normal. 10 times, went from 200 to 2,000, 2,000 to 20,000. Overnight, it's just doubling, tripling, quadrupling. So significantly high. So if I tell you significantly high HCG levels, the patient doesn't know what their HCG level is. How might they present to you though, that you think, this is not right? What does HCG cause? Why do we get something earlier on in pregnancy than we do later in pregnancy? I know, it's 3 to 5. Nausea, vomiting, right? Nausea, vomiting. These patients are not coming to you going, I think my HCG level is really high. They're checking their pulse, right? No, they're coming because I have nausea. I have such severe nausea and vomiting. I can't even eat anything. I'm so sick. Okay? And that's because these HCG levels are so high. On ultrasound, for complete no embryo, no fetal formation, just this abnormal cluster of chorionic villus, abnormal amount of trophoblastic cells that we can see. On ultrasound is typically described as a cluster of grapes appearance or even a snowstorm appearance. Okay? And again, hyperemesis gravidarum. This is severe nausea and vomiting very early on in pregnancy is typically when this is diagnosed. If they have a partial molar pregnancy, unfortunately with this, it's a little bit more difficult to diagnose because HCG levels could be at the high normal range. Okay, they oftentimes will still have nausea and vomiting, but not to the degree we're going to see in that complete molar pregnancy. The embryo or fetus is identifiable on ultrasound, and sometimes it's still viable, meaning it still has a heart rate. Okay, ultimately, that baby is not going to survive, and it's not even a properly developed baby. Okay, or the baby never really developed, but it can have fetal cardiac activity. So what we see on that ultrasound, if it's a complete molar pregnancy, we can see here just what looks like pieces of grapes in here. Okay, and then here you can see those cystic areas, those anechoic areas, but also you see that fetus that's in here. So my best friend from high school, her first pregnancy was a molar pregnancy. And she went in because she was having vaginal bleeding, and she said she was probably about 8 or 9 weeks, but she said she felt like she was 17 or 18 weeks, like her stomach was really, really super big. But this was her first pregnancy. She didn't know. She was like, I don't know, I just guess this is normal. Eating too much, those kind of things. But ultimately they said, no, you have a molar pregnancy. And so I think they discharged her home that night with the plan for her to follow up with OB the next day. So she goes home, but she's in the shower and she starts really bleeding a lot. But what she said was the most interesting was it was blood coming out, but it was like grape seeds were coming out. Is what it was like. Clear seeds were coming out. And she said if she touched them, they would pop. And she was just like, oh my God, this is the weirdest thing ever. But again, her first pregnancy, she's like, I know this is not right. But that's how she described these cells or these things that were coming out as clear grape seeds that would pop when they came out. And she had ended up having a complete molar pregnancy and ultimately had a DNC done for management. And then she, the end result, she had 2 other healthy babies. But the other thing that happened to her, so she gets her DNC, and a month or so goes by, and she's starting to feel like she's pregnant again. Like her belly's getting bigger. And she goes in to get seen, her HCG levels are increasing. She ends up having malignant transformation. Very rare, 0.1% of gestational trophoblastic disease after treatment will come back from those remaining trophoblastic cells and be malignant. And again, mind you, she was only about a month out. She already had metastasis to her liver, to her lungs from this malignant transformation. Okay. Treatment for this, chemo, high dose chemo for several months, and then again, she ultimately was able to have 2 completely normal pregnancies after that. So about 1% of these molar pregnancies these patients will come back with either vaginal bleeding, increased abdominal girth, nausea, vomiting, and they're found to have malignant transformation. More commonly seen in complete molar pregnancies over partial, and again, should be suspected when that uterus is starting to enlarge or doesn't go back to normal size. You know, when you're only 8 weeks pregnant and you're looking like at 15, once they do that DNC, within a week or 2, those cells, the uterus should be back down to normal size, well, maybe 2 to 3 weeks. That doesn't happen, then this needs to be in the differential for these patients, because they'll probably come to see you first. And this is called a choriocarcinoma, that malignant transformation. So signs and symptoms, again, more common in complete molar pregnancies, but we do have that first trimester bleeding, high levels of HCG. These patients may actually come in with signs and symptoms of hyperthyroid. The TSH may actually be super, what, high or low? Low. Hyperthyroid, low TSH. Why? Because TSH and HCG look very chemically similar to the body. And so when you have such high levels of HCG, it causes this like thyrotropin effect. And it will in fact affect the thyroid. So how does that present? Tachycardia, sweating, flushing, so that's how they may present as well. They may even present like they're preeclamptic. Matter of fact, in a person that comes in and they have no history of chronic hypertension, okay, and now they're coming in before 20 weeks, remember this is going to be probably a little bit earlier on, and they're all of a sudden they have high blood pressure, molar pregnancy needs to be on your differential. Because that would be unusual. You normally aren't going to, if you come into your pregnancy, chronic hypertension, okay. Okay, if you develop hypertension after 20 weeks, pregnancy-induced hypertension. But it's unusual to come into a pregnancy not have hypertension, then at 10 or 12 weeks develop hypertension. So if they develop hypertension earlier on in pregnancy, that's unusual, and they didn't have it, you need to have this as your differential molar pregnancy. Again, significant nausea and vomiting, and then uterus that looks big. It looks like we should be able to get fetal heart tones, but no fetal heart tones identified on either Doppler or ultrasound, especially in that complete molar pregnancy. Labs, CBC, CMP, HCG quant, ultrasound is going to be the radiologist of your choice. Ultrasound. If we suspect, so this person was treated, they came back, and uterus did not go down to size, then we suspect some sort of choriocarcinoma, chest x-ray, CT and pelvis, because now we got to figure out, is there any evidence of metastasis? We have staged this. And that helps them develop the treatment plan for these patients as well. Okay, so the preferred treatment, if they have a molar pregnancy, is going to be a DNC. And then after the DNC, this is important as well. After the DNC, Now we've got to monitor those HCG levels. So serum beta HCG levels every 1 to 2 weeks until they are undetectable. So that's about an average of 9 weeks or so if it's a complete molar pregnancy. It takes about 7 weeks or so for a partial molar pregnancy. Now, you don't need to know the 9 and 7, but you need to know we've got to watch these HCG levels until they're undetectable. Okay, and then, once they're undetectable, we're going to continue to monitor it every month for 6 months, the HCG level. Why are we monitoring? Cancer. We've got to make sure we don't have development of cancer. And we've got to make sure we don't have development of cancer because we have this open area and cancers can develop this. We're going to monitor for 6 months. A birth control is recommended during this entire surveillance period. Okay, they do not want these patients to get pregnant until they can completely clear them. And I think for my best friend, they told her a year. They recommended she wait a year until she had her baby. Whereas for Rh negative women, they still recommend RhoGAM to be given. And then if they have gestational trophoblastic neoplasm, choriocarcinoma, chemotherapy, and if they're resistant to that chemotherapy and they still have disease, then they're going to recommend a hysterectomy for these patients. Otherwise, a future fertility doesn't seem to be affected. It doesn't mean they can't get a reoccurrence of the molar pregnancy, but they seem to be able to get pregnant just fine. Okay? Even after successful treatment of with chemotherapy, they can still get pregnant. But again, the recommendation is to wait for 12 months, just like they did with my friend Sharon. Okay? All other pregnancies, they're going to take the placenta and they're going to send that placenta off to the lab to evaluate for any evidence of the abnormalities. And then serum HCG levels are going to be checked 6 weeks postpartum to make sure there's no evidence of rising HCG levels. Implantation bleeding, another cause of first trimester bleeding. Typically small amount of spotting, usually once or twice, either on the tissue, a little bit on the undergarments. Occurs about 10 to 14 days after fertilization. So at that time when they would think they kind of missed their period. Again, quarter of all pregnancies, this effect, so pretty common. And when they come in, it's still got to be a diagnosis of exclusion. You're going to do the HCG level. You're going to do that transvaginal ultrasound, make sure there's no other reason, and then there's no treatment message. If you don't identify anything abnormal on ultrasound, yep, you've got an intrauterine pregnancy, good fetal cardiac activity, HCG level is okay, H&H is okay, there's no treatment necessary for these patients. Other causes of first trimester bleeding, infection can cause this. You want to have a high mix suspicion if someone comes in, vaginal discharge, or have multiple sexual partners. You want to talk to them about that. Any sort of trauma, of course, to the vaginal area, perineal area, lacerations, polyps, cervical polyps. We know, especially intermenstrual bleeding or postcoital bleeding for these patients. And then fibroids, we already talked about that. You can go interpregnancy with fibroids, and those fibroids are still going to bleed, especially because fibroids are very well estrogen sensitive, so they often increase a little bit during pregnancy, so they can have bleeding with that. Right. Second and third trimester bleeding. So now we're thinking about bleeding that's occurring after 14 weeks. Definitely not going to be seen near as often, thank goodness, as we're going to see in that first trimester. We think about things like placental issues or improper placental implantation or abruption. There could be problems with the umbilical cord that could cause bleeding. They could have cervical insufficiency. They could still have an infection. They could still have trauma. They could still have leiomyomas throughout that second trimester. So some of those first trimester issues can be seen in the second trimester as well. We're going to focus on those that we have not talked about yet. You need to identify, is this painless bleeding or is this painful bleeding? So painless, placenta previa, the number one cause of painless bleeding. Okay, cervical lesion, cervical insufficiency, a bloody show, that is going to be loss of the cervical mucus plug, and that's going to occur much more towards the time of labor. as that cervix begins to dilate. That's not something we should see when this person is 22 to 24 to 26 weeks. That's going to be more 36, 38, 39, 40 weeks, right? And then vasa previa, rupture can cause bleeding. If it's painful, number one cause of painful second or third trimester is placental abruption, and then the other one is uterine rupture. Uterine rupture especially can occur if someone's had a prior uterine surgery or prior previous C-section surgery, where that uterine lining or the uterus, the muscle itself is just not quite as strong as it used to be. And so especially if you have a multi-gestational pregnancy, really stretches that uterus out, and that can rupture. That's going to be, imagine, pretty darn painful. Okay, so on physical exam, you want to do an abdominal exam. An abdominal exam, we assess the size of the uterus. Remember, at 20 weeks, we should be at the umbilicus. At 12 weeks, we have the pubic symphysis. Okay, we want to identify, is there any tenderness on physical exam? Fetal cardiac activity. In that second and third trimester, we should be able to just use a Doppler ultrasound. Okay? We should have identified fetal cardiac activity on Doppler a long time ago, like in that about 10 weeks or so, right? So we should be able to continue to hear that with the Doppler ultrasound. If for some reason you can't, then we're going to grab an ultrasound, and we're going to look on that ultrasound for that fetal cardiac activity. 150, 160. Okay. Now, it's important that, again, if this is, especially if this is painless, when we do our exam, we do our abdominal exam, you want to avoid any digital penetration until you can rule out a placenta previa. Okay, so you do not want to do a digital exam. We usually will even wait to do a speculum exam until we get an ultrasound and make sure that ultrasound does not show placenta previa. Okay? Because if there's a placenta previa, meaning the placenta is overlying the cervix, and you stick your finger in there and actually stick your finger all the way through the os, you can rupture that placenta, and these patients will die in front of you. Okay? So you have to be really careful with that. So you want to withhold the digital exam, withhold the speculum exam, and try to get an ultrasound first, make sure that placenta previa is not the problem, and then we can go on and do our digital or speculum exam and ultimately digital exam. Labs, we're going to check the H&H. We're going to do an ABRH, see if mom is already positive or negative. Remember when you do that ABRH, and these patients, had one at the beginning, but really they're only good for 30 days. And as much of a pain in the butt as it is to have to redo it, like, we already know this patient is whatever blood type, you got to repeat it again. Lab will not accept it. If you need to order blood for patients, they must have one within 30 days. Okay? So type and screen, type and cross if necessary, especially hypotense tachycardia. They're bleeding significantly, decreasing H&E. And then ultrasound. So we think about transabdominal ultrasound might be the first one that can be done, or first one to be done, because again, we're trying to make sure we don't have placenta previa. If we don't want a speculum in there, if we want to do a digital exam, we definitely don't want an ultrasound in there, because those ultrasound probes, vaginal probes, are about this long. So it doesn't take much. Remember that cervix gets soft farther along we go in pregnancy. So it doesn't take much to push that in there and accidentally penetrate into that placenta. Okay. Most of the time, if you write on there eval for placenta previa, if they choose to do the transvaginal, okay, they'll be extremely gentle. They will not put the probe in like they normally would do in a non-pregnant patient or in a person that you're not concerned about placenta previa. So make sure you document that in your order form if that's what you're doing. Otherwise, they'll do a transabdominal first, and then transvaginal is still going to be your gold standard to fully evaluate that placenta previa. So placenta previa can occur in a couple of different fashions and forms, okay? But again, painless bleeding before 20 weeks, and this can occur earlier in pregnancy. It can be identified on the fetal anatomy scan at 18 to 22 weeks. They can say, oh, yep, there's a placenta previa, we got to watch it. But as the baby grows, what does it do? It can pull that placenta up and away from the cervical os. Okay? As the baby's growing, they're pulling that placenta up and away. Okay? Occurs in about 1 out of 200 pregnancies, so definitely maybe something that you need. And there's not a lot we can do to prevent this. However, we have things that can increase the risk. So if mom is a smoker, say, hey, just by you smoking, you increase your chance of placenta previa. People that have assisted reproductive technology, increased chance of placenta previa, if they have a history of it. If there's a multi-fetal gestation as well, an increased chance that the placenta is going to overlie the cervix to some degree or another. So again, this is our normal placenta. This is where we wanted our baby to implant in the upper portion of the fundus so that the placenta can be far away from the cervix. Okay, you can have a marginal placenta previa where it just touches where that cervical os is. Bless you. Okay, so here's the cervical os, and the marginal is right on the margin of that internal os. You can have a partial placenta previa, we're talking about halfway over the cervical os, and then you can have a total or a centralis, where it completely covers the cervical os. Okay. What do you think the treatment, what are they going to do with these patients when it comes time to deliver? C-section. Even the marginalis one? Yes, because who knows? That baby comes out a little rough and tough and grabs a hold of that placenta and works on that. We got a whole lot of problems. Okay, so with any of these C-section deliveries. So diagnosis, usually a transabdominal, okay, and that's really again to identify where is that placenta located, and then ultimately they may do a transvaginal. When they do a transvaginal, they're going to be super sensitive with it. Only typically insert it for a couple of inches so they can just identify and give the pictures that they need. And usually that's going to be between 32 weeks and again at 36 weeks. Again, we're trying to give mom and baby the opportunity to fix this placenta previa. Ideally, we'd like these patients to do a vaginal delivery. But at 36 weeks, if we have a persistent placenta previa, they're going to go ahead and schedule these patients for a C-section. So treatment, okay, if it resolves on its own, then they're just going to continue to monitor. Okay, if not, if it persists, at 28 weeks, they're going to recommend pelvic rest. So no intercourse, no visual gland, nothing inside the vagina. And then delivery via C-section at 36 to 37 weeks. They'll schedule that. I can have that done. No vaginal delivery in any of these placenta previas. We got to remember baby first, then placenta. You can have placental abruption. Painful or painless? Painful. Painful. Placental, anything that says abruption sounds very painful. But placental abruption, the expectation is we go through stage 1 of labor, we go through stage 2, that's the pushing stage, we get baby out of it. And then stage 3 is the placental. Well, this is what's happening. What's happening with this placental abruption is before stage 3, okay, before stage 2 and earlier, the placenta is pulling away from the lining of the uterus. It's abrupting away, pulling away. Okay, occurs about 1% of pregnancies. The problem is yes, most of the time it's painful, okay? Most of the time you have bleeding, but not always. It depends on where and how the abruption occurs. Okay? Typically, we're going to see this before 37 weeks. And if it does occur, we have a high mortality rate associated with this. Okay? Again, 3 different types of presentation so we can see this. You can have marginal, central, and complete. Okay. So marginal is the one that we're going to see vaginal bleeding with. We can see our placenta here, and just the end portion of that placenta is starting to pull away, just enough for us to have bleeding to occur in those vessels. We're going to have vaginal bleeding. Probably a little bit of discomfort that's associated with that. Okay. Here, though, if we look at this one that says central abruption here, there's a high likelihood this patient's not going to have vaginal bleeding. Okay. They may have abdominal discomfort. It may not be like, oh my God, I feel like someone just kicked me. It might be like, man, I don't know, I'm just having some pretty decent cramping, which is unusual. I haven't had this before. But probably no bleeding. And when they do the ultrasound, it's super hard for them to see that. So sometimes even an ultrasound, this can be missed because it's hiding behind the placenta. Okay? If you have this complete separation, these patients tend to be quite a bit more painful. These patients are going to be quite a bit more pain. Okay? And this is more apt to be seen on ultrasound because the amount of bleeding. But you could hold easily 2 liters of blood behind that placenta and not know it. So that's what I'm saying is these patients, if they come in and we've got one of these, some of these significant ones, and we're lucky it's a marginal one, and we're having some bleeding. If we're unlucky, they're going to continue to bleed and bleed and bleed, and essentially bleed internally. So we don't really know why this occurs. However, there are a lot of risk factors. Break this up into 3 different categories. Mom, okay, health history. Most commonly associate women with hypertension, whether it be chronic hypertension or pregnancy-induced hypertension, gestational hypertension. Okay, but most commonly associated hypertension. But smoking, cocaine is back again. Cocaine is always the problem, right? Always the problem and always the solution too. But cocaine use, increases the risk. And then advanced maternal age, more apt to be seen. Okay. Current pregnancy, if they have preeclampsia, well, what is preeclampsia associated with? Hypertension. Okay, so if they have preeclampsia, or if this is a multi-fetal gestation, then they're also more apt to have placental abruption. And then any sort of trauma, whether it be an MBC, whether it be a small fall, I slipped down the stairs, landed on my butt, did not hit my belly, that's still jarring. Okay. Or of course, if they get hit in the stomach, that increases their risk as well. So that's when we talked previously about antenatal unit. Antenatal unit, these patients with hypertension, with preeclampsia, with history placenta previa, or any complications, they're going to start going to the antenatal unit fairly early on. 28 weeks or so, maybe a little earlier, to monitor for these kinds of complications. Fortunately, there's no physical exam, there's no lab, there's no radiology study to definitively diagnose this placental abruption. So we've got to have a high index of suspicion in that 2nd and 3rd trimester vaginal bleeding. Certainly if they have any sort of abdominal discomforts associated with it, either they complain about that or you feel it on exam. Okay, speculum exam is typically okay, but we do not typically recommend a digital exam in these patients. And remember, as you go in that 2nd and 3rd trimester, they do recommend that these exams be sterile exams. So you don't introduce bacteria into the vagina, increase the risk of infection. A lot of times they'll monitor mom that has chronic comorbidities. They're going to monitor mom for tachycardia or hypotension. And hypotension indicates they're bleeding somewhere. Now it's just trying to figure out where they're bleeding. Okay, uterine contractions are going to be monitored. Fetal heart rate will be monitored with those external monitors. Okay, remember that fetal heart rate, fetal cardiac activity is actually using an earlier sign of maternal issues than maternal vital signs themselves. And then transabdominal ultrasound, maybe a vaginal ultrasound. Unfortunately, not super sensitive. Look, only detects about 2% of abruptions. So why are we doing it? Because the person's coming in with 2nd or 3rd trimester vaginal bleeding, we've got to make sure this is a placenta previa. Okay? And if we're lucky, we'll catch a placental abruption. But oftentimes, these patients, this diagnosis is not made until after delivery, when they look and they're like, holy cow, the placenta has abrupted away. I saw a patient in the ER maybe about 6 weeks ago that had this happen. She had no idea, completely normal pregnancy until the very end when her blood pressure shot up. And so they did immediate induction and vaginal delivery. When they did that vaginal delivery, she had abrupted 3/4 of the placenta away. Okay. So had a little bit of postpartum hemorrhage there to manage that, and she was otherwise doing fine. So again, oftentimes on ultrasound not beneficial, we see it afterwards. Okay. Some other placental complications that we may see: placental accretia. placental accretia. Now here, we have a normal implantation of the placenta, this top one, where it just comes to the endometrial lining. We talk about placenta accretia or accreta. It goes just a little bit deeper than the endometrial lining. So it really is trying to hold on. Well, that can be a problem when it comes time to deliver that placenta, because the placenta gets kind of stuck in the endometrium. We've got placenta increta. Placenta increta, where it goes into the myometrium. Here it's extending midway through the myometrium. So that really presents a problem when it's time to deliver that placenta. And then placenta percreta, all the way out through the uterus, through the wall of the uterus. Like, that's insane. So these patients, oftentimes you can't identify these on ultrasound. Okay, what happens is you're going to deliver the placenta and the placenta is not coming. So we do a little bit of a tug on the placenta and it's still not coming. Okay, this have very complicated perinatal issues. So once they deliver baby, trying to get this placenta out, sometimes results in significant hemorrhage. And ultimately, these guys may have to do an open abdominal evaluation to be able to control bleeding and get the placenta out. All right. So, but you got to know those differences, what the difference is between those three. All right. We can have umbilical cord problems. Okay? Umbilical cord problems, we'll talk about two of those. One is velamentous cord. In fact, up to 15% of pregnancies, and will come in if you have multi-pregnancies, so multi-gestational pregnancies, 15% in triplets, 1% in just single-term pregnancies. What a velamentous cord is that, so normal insertion of the umbilical cord comes out of the baby's umbilicus, goes into the middle of the placenta. A velamentous cord inserts at the end of the placenta, and the latter portion of the cord, so the cord itself is normally wrapped in this protective gel-like substance, like, what is it called? Wharton's, I think it's called Wharton's jelly or something like that, right? So it has this gel-like substance around that holds the vessels in place and protects them. Well, the distal portion of those vessels don't have protection. They are just running out naked. They don't have any protection, and they're inserting at the end of the placenta. So not only is there risk for rupture of one of those vessels, but also because it's inserting at the end of the placenta, baby is not getting the nutrients like it normally would. Because now the nutrients have to go all the way from the end of the placenta, all the way through to get to the baby. So we got here's the umbilical cord, the nutrients are coming this way to get to the baby. So the baby oftentimes has low birth weight. That might be one of the first signs and symptoms of this is a velamentous cord. And then we'll be able to see this action on ultrasound. It takes a lot longer for the nutrients to get to baby, so baby's not able to feed as well. This isn't typically necessarily a risk for bleeding during pregnancy. It's more for a risk for bleeding around the time of delivery, so antepartum time period, because of those vessels that are exposed. Again, normally it inserts right here in the middle for the umbilical cord. With a velamentous cord, we've got it inserting at the end of the placenta, and look here. All of these vessels are not covered in this Wharton's jelly. These are all good to go, but at the end here, these vessels are just open. So it doesn't take much to tear those vessels off and have significant bleeding from those vessels, especially during the time of delivery. Okay, so that is a velamentous cord. So diagnosed on ultrasound, and no specific treatment. They can't go in there and fix it, they're just gonna monitor fetal growth. And if they're really concerned about blood vessel rupture, they'll schedule mom for a C-section. They won't allow mom to deliver if they're concerned if there's concern about blood vessel rupture. Okay. We also have a vasa previa. So vasa previa oftentimes, I shouldn't say often, but can occur in association with this velamentous cord. So So you have those unprotected vessels from the velamentous cord. And then vasa previa just really means that the umbilical cord is overlying the cervical ox. So baby's head is up here and the umbilical cord is down here. And then the cervix is here. That's not how we want it. We want baby's head to be down here and the umbilical cord to be over here. But the umbilical cord is overlying the cervical ox. Okay? One in about 2,500 pregnancies, and again, it can be associated with those unprotected blood vessels when we see with the velamentous cord. These patients may have vaginal, painless vaginal bleeding. We may see fetal bradycardia. Okay, why do we think we see fetal bradycardia? So if baby is descending down, we've got the umbilical cord down there, compression against that cord, also, if there's not a lot of amniotic fluid and the cord is down, then we get compression against that cord. So anything causing compression against the cord. And again, if it's associated with this velamentous, then we have increased risk of some pretty significant bleeding, usually death within just a few minutes if one of those vessels ruptures. Diagnosis is on the ultrasound. They'll be able to identify pretty quickly if that cord is overlying the cervical ox. And if it is, then that's a C-section. We cannot deliver baby through an umbilical cord, okay? Especially if there's velamentous bleeding, so you can't deliver baby through there. Matter of fact, if mom goes into labor, then there's a higher risk that this cord will prolapse out of the vagina, and that is an immediate C-section. Okay? If you ever see that, you just take your hand and hold things in place and call for help. Because there's nothing else. Trindle under mom a little bit, hold. You don't want things coming out, okay? Because it'll rip that cord right in half and then you'll bleed to death within minutes. All right. Cervical insufficiency, we've talked about this lots of times. Incontinent cervix, painless second trimester cervical dilation, ultimately leads to vaginal bleeding and then expulsion of the fetus. So fetal demise, miscarriage in our second trimester. Oftentimes, if it happens in one pregnancy, it happens in future pregnancies, which is why we talked about this as a cause of recurrent miscarriages. This can be due to cervical trauma from repeat LEEP procedures, DNCs, CKCs, which is that colonization, or even colposcopies. And then sometimes it's because mom was born with an abnormal cervical development. If that can be identified, then they can do a cerclage where they're going to sew up the cervix. That's our door to keep baby in. And they'll just use sutures and that'll stay in for the remaining portion of the pregnancy. And then when they're ready for mom to deliver, mom can still deliver vaginally, right? They just take the sutures out and here we go, ready to go. So about the time for labor and delivery, we'll take those sutures out and allow mom to continue through labor and delivery normally and deliver vaginally. Trauma can be seen in upwards of 20% of pregnancies. Could be major, could be minor, could be blunt or penetrating trauma, could be intentional or non-intentional. So all ways that we can get trauma. Remember that again, the fetal heart rate, if we're able to monitor that's going to give us an earlier indication of mom's well-being than mom's vital signs themselves. So it's nice to monitor mom and baby. And if we're starting to see fetal tachycardia, that's an indication that there's something going on with mom. Again, sources of blunt trauma. MVA would be the number one cause, okay? Number one cause of non-obstructive fetal demise. You gotta be careful about that. Falls, physical assaults. You can have complications that are associated with this blunt trauma. Placental abruption can occur. Uterine rupture certainly can occur. Fetal injury, depending on, especially on how far along mom is in her pregnancy. And then hemorrhage can always occur anytime you have any trauma to the abdomen. In minor trauma, fender benders, maybe like I said, fall down a couple of stairs. Sometimes abuse can be minor, sometimes it can be major. If any of these, major or minor, we want to consult OB. If it's major trauma, our priority is still gonna be mom. That's gonna be our priority in managing her, in managing life-threatening injuries. And secondarily, it'll be fetal. So if you ever, for any of you that are gonna be training at BMC, if you ever hear like, oh man, what do they say? I don't know, they just kind of put it out there, like OB emergency, OB trauma in the ER. About 500 OB people descend on the emergency department, and they help take care of mom, and they help take care of baby, which is great, because that's a lot less than we have to do, right? But even in minor trauma, something you think is minor, you still should call OBGYN and get them involved in the care. This is what happened, what would you like me to do? Okay, for our assessment, EFAST is important, ultrasound, CT if needed. Okay, we're not going to withhold a CT just because mom is pregnant. If we need that, we're going to do CT. Okay, we want to identify if there's been any vaginal bleeding. That can be done by mom's history, can be by physical exam, and then ultrasound will help us with that as well. Any evidence of rupture of membranes, again, history. Do I see pooling of kind of clearish or serosanguinous fluid in the vaginal wall? Let me pull out my nitrazine paper and see what pH that fluid is. Maybe that's my indication. Ultrasound. Ultrasound, especially if you've had prior ultrasounds, ultrasound might indicate a decrease in the amniotic fluid. And now after an injury, whether it be major or minor injury, that would be an indication that mom is losing amniotic fluid somewhere. And then we've got to make sure we do that ultrasound to help us identify if there's any evidence of placental eruption. If mom is more than 20 weeks, she must be monitored for at least 4 hours. Okay? And we're going to give OGM if mom is already because even in these minor traumas, there's a high risk of maternal fetal blood mixing. Okay, when can we discharge these patients home? We gotta know this. Circle, star, all of these things. And look, I'm telling you right now, 4 to 6 hours. For those of you that choose to send this patient home at 2 hours, you're going to get it wrong. 4 to 6 hours. Cannot be contracting. Less than 1 every 10 minutes. So they can still have contractions. Okay, if there's 37 weeks, you're probably gonna have some, but 1 every 10 minutes. Okay, that's what we're looking for. Less than 1 every 10 minutes. Can't have black vaginal bleeding. Can't have abdominal pain or tenderness. Fetal heart rate needs to be reassuring, which means that you know what reassuring means. You gotta remember what reassuring means. Okay? You guys remember? Everything 32 weeks, less than 32 weeks, 10 by 10, 15 by 15. So we get the acceleration, 110 to 160, all of those are reassuring. Okay? No visible bruising on the abdomen. If they have any of those things, they gotta come in. Okay, so 4 to 6 hours, if all of those things are negative, they're all of them good, then we can send mom home, but not prematurely. I feel great, I wanna go. Well, you can go, but you need to sign this here that says against medical advice. Again, major trauma. Okay, we're gonna manage this just if they were not pregnant. Evaluate and treat mom first. That's our first priority. And then fetal evaluation comes in our secondary survey. Once we assess mom and stabilize mom, fetal evaluation will come in the secondary survey. And remember, depends on how gravid these patients are, how pregnant they are. You may be best off evaluating them in the left lateral decubus to get them off of their major vessels. So you're like, man, I don't understand why these patients are so hypertensive. I can't find bleeding anywhere. Maybe because they're laying straight on their back. Get them up off their back. That's how the assessment should be. Okay, unless someone comes in there and tells you to do it. Otherwise, they should be up on their lateral decubus. This is how they should be from the very beginning. And usually we just take a couple of towels, roll up underneath them, and it'll help them push them up. Okay, there's a lot of other pregnancy complications. The last one, the first one we're going to talk about, and the last thing for today is hypertension. So if we can get through this or not. Probably won't be able to, but we'll try. Hypertension, very common, 10% of all pregnancies, but leading cause of maternal mortality. Okay, so we want to make sure that we identify those patients that have chronic hypertension, and those patients have a risk of developing. So maternal age greater than 40 when they're pregnant, that's an increased risk for developing hypertension. If they have pre-pregnancy obesity, so pre-pregnancy higher BMI, increased risk for developing hypertension. If they have excessive weight gain during pregnancy, also increased risk, or if they have diabetes, gestational diabetes, meaning they didn't have necessarily have diabetes going in, but they developed diabetes, then that increases the risk of hypertension as well. All right, now, there are different definitions associated with pregnancy and hypertension. If they have hypertension before 20 weeks, or has hypertension that persists beyond 12 weeks of pregnancy, or 12 weeks postpartum, and that is considered chronic hypertension. Okay? Chronic hypertension. You can also have chronic hypertension with superimposed preeclampsia, meaning now we're starting to have some signs and symptoms. Hypertension after 20 weeks of pregnancy, but resolved before 12 weeks postpartum, is considered gestational hypertension. Okay, and then we have other forms of hypertension, or things that hypertension can lead to: preeclampsia, HELLP syndrome, and eclampsia. So we'll talk about all of those. All right. So again, chronic hypertension. I have a pre-pregnancy diagnosis of hypertension. I am hypertensive, and I am pregnant. That is chronic hypertension. Or, okay, if someone says, all right, I did not have hypertension at all before pregnancy, okay, greater than 140/90 blood pressure, I developed hypertension at 20 weeks, but now I'm 12 weeks postpartum and still have hypertension, that is also considered chronic hypertension. Okay, so it's either happening before, or it started in pregnancy and persists, because if it's just gestational hypertension, it'll start after 20 weeks and it'll stop within 3 months postpartum. Okay? If it's chronic, it's going to continue on beyond that 3 months. I am 6 months postpartum and still have hypertension. You are now chronic hypertension. Okay? And again, greater than 140/90 on 2 occasions, at least 4 hours apart. Prior to 20 weeks, or it extends beyond the time of delivery, 12 weeks beyond that, and I still have hypertension. You guys get that? Make sense? I either got before, or it's going way longer than it should. Okay? Now again, if someone has new onset hypertension, we talked about this already, new onset hypertension, okay, in a person that doesn't have it, we need to be thinking about why are they developing this hypertension? Why? Okay, is it someone that has something like gestational prophylaxis? Well, we'll figure that out fairly early on. But other things, is there something affecting their kidneys? Do they have a FeO? Do they have connective tissue disease? Do they have, hyperaldosteronism? Why are they developing hypertension in pregnancy? Okay? If they've had normal pre-pregnancy BMI, they have an excessive weight gain, and so this may be not something you will work up, but it's something to think, but hey, wait, this is my time to refer, because I don't understand why you're developing hypertension when you have no risk factors for it. If someone has chronic hypertension, we're going to treat the chronic hypertension. We're going to talk about diet and exercise, and make sure they're not having excessive weight gain, and we're going to give them medication: labetalol, nifedipine, methodopa, ACTZ. Okay? But what we can't use are ACEs. We can't use ARBs, and atenolol as well. We can use labetalol, and we can use other beta blockers. We cannot use atenolol. We cannot use atenolol. It's teratogenic. So we don't want to use it. ACEs, ARBs, atenolol, not used in pregnancy for hypertension. Okay, but labetalol is used pretty often, nifedipine. And then African Americans, we can use some like ACTZ as well. Typically, if they have not used ACTZ before pregnancy, then it's not something we typically would start them on. We'll use one of the other ones, usually labetalol. Okay, ideally, we'd like to have a blood pressure less than 140/90. Remember, blood pressure is normal. It dips down a little bit, and it comes back up to kind of what low normal. When we're up at 140/90, that's significant. We want less than that. Can we also recommend low-dose aspirin for these patients? Low-dose aspirin that begins after 12 weeks because in turn will help us reduce the chance of them developing preeclampsia. We have lots of studies out there that show that. And this is something just in the last 1 to 2 years, maybe about 2 to 3 years that we started doing. So treat their chronic hypertension. Okay, gestational hypertension occurs about 6% of pregnancies. So new onset greater than 140/90 after 20 weeks and no proteinuria or other signs and symptoms like headache, vision changes, lower extremity edema. And it resolves prior to 12 weeks postpartum. So we got 20 weeks has to be 11 weeks and 6 out of 7 days. As long as it resolves in that time period, it's considered gestational hypertension. Again, if it persists beyond that 12 weeks, we now say you have chronic hypertension, and needs to be managed like chronic hypertension. Okay. Patients that develop gestational hypertension, up to 25% of those will develop preeclampsia. Okay, that's it for today.